Understanding Rural. I'm Erin Borla, Executive Director and Trustee of the Roundhouse Foundation in Sisters, Oregon. Healthcare is top of mind for so many Americans, and rural healthcare is a beast unto itself, with its own set of challenges. One of the things that I love about rural parts of this country is that they can be incubators for new ideas. People get together in small communities, look at what's broken, and find ways to fix it. Benjamin Anderson is doing that with rural healthcare at a time when our country needs leaders like him more than ever. He's the president and CEO of Hutchinson Regional Medical Center in Hutchinson, Kansas. He sees the nonprofit hospital system he runs as a nexus, a hub that sends ripples of health into the community as a whole. And he puts that community at the center of everything the organization does.
It is a safety net health system that cares for all people and those who can't pay. So regardless of a person's background, every human being that walks into this health system has equal intrinsic value, equal inherent value. And that is a universal value across this organization. Our mission is to, entrusted with people's lives, we make health and healing available to all. That isn't some, that's not only the insured or only a person from one background or another, but that's anyone who walks in here. And so that's something that unifies all of us. And with that comes a tremendous responsibility, because the way our system is set up, there isn't the right money in the right places to enable or empower a health system to function properly. So you cobble together all these disparate payer sources, and you need all of them to make it work. And we do that. And with that, and with the help of our foundation, we're able to meet the needs of our community.
It's so impressive because I know healthcare costs are rising. There are so many challenges to getting healthcare to rural places. Let's talk big picture to start. How
Sure.
would you describe the state of rural healthcare in this country, and maybe some of the bigger challenges that we're trying to face broadly, and then how you're addressing those?
We're coming off a season, really 20 years or more, where this term inclusion has risen to the center of the national conversation. And what we're dealing with in rural health now is the aftermath of the inclusion movement excluding rural America. So inclusion may have been around socioeconomic disparities in urban areas, or around racial disparities, or LGBTQ, or gender disparities, but really there has not been representative conversation when it comes to geographic disparities. And in this country, where you live determines or affects how long you live. And the phrase we'd use for that in rural America is, that ain't right. Your zip code need not determine your life expectancy. And right now, there is a direct correlation. And so we are having to stare down our national creed in the context of rural health. We hold these truths to be self-evident, that all people are created equal. They're endowed by their Creator with certain inalienable rights, and among these are life and liberty and the pursuit of happiness. And what we are watching happen is 20% of America saying we count too. We're in the conversation. We have a seat at the health equity table. And so there's very important work that has to be done in the coming weeks and months to ensure that really our national creed is, in fact, our reality. We do hold these truths to be self-evident.
And I think we see that played out in a variety of ways, right? Whether that's where the rural voice is missed. I was having a conversation with another funder that funds in rural healthcare, that we have these national conversations with 25 different health systems talking about cancer care or maternal health. And they have a rural voice, but it's one person of the 25, often from a community of 200,000, 250,000, and that constitutes as the rural voice. What are some other ways that you're seeing that we could show up in a better way, or show up more collaboratively to include that voice?
I love what leaders among tribal health systems often say, which is nothing about us without us. If we're going to make decisions around policy, and those policy decisions affect whether people live or die, let's ask the people and involve the people who would be most directly impacted by those policies. Have a seat for them at the table. And that's not a token seat, right? just as we wouldn't want to have a token person representing one race or one gender or one socioeconomic background. We want to make sure that there is adequate representation in those discussions. So if 20% of the people that are going to be affected by a health policy are rural, let's have 20% of the people in that decision-making pool be rural. And so on and so forth across the board. If we overlook any disparity, we risk legitimizing all disparities. We can't say one disparity matters more than another. The numbers we have to reconcile with these numbers that don't add up around equity. And that includes all of us.
Mm-hmm. Yeah.
So we invite the people at the table that are most affected. Some of the most innovative solutions to our most complex problems come from the people most closely connected to those problems. They know the answers. If we bring them to the table, we give them a microphone that works, they'll speak up, and we will end up with a better outcome.
And some would say, how do we fund those outcomes? Like, what's the next step, right? Beyond just getting the voice at the table. This shows a lot about how we can get additional dollars to these places, and used to be leveraging federal resources, but now it's really just leveraging any resource.
Any resource. That's right. How do we fund them? Well, some of the best solutions actually don't cost that much money. So what we say is that there's a 4-part process for us that we use that we believe is universally relevant. And the first one is identify the right thing to do by asking the people most affected. If we skip the part where we ask the people most affected, we start assuming, and if we assume wrong, people die, right? So we identify the right thing to do by asking the people most affected. Once we've identified that, then we hack the system, bootleg the funding to do the right thing, because if the right thing was already funded, it would already be done. But we are what we're incentivized to be. And so that's where philanthropy comes in, is because they can fund innovative, crazy stuff that traditional payer sources can't do. They can pilot stuff that seems nuts. But we could try something like that once we've identified the right thing. And the third step is to track the outcomes, meticulously track the outcomes for doing the right thing. And then fourth is to tell the story and use it to change policy, use it to change best practice, improve best practice, and then start over. Now, what's the right thing to do now? Well, we got to ask the people most affected, how'd the last thing work? And is there something we can learn from that? All right, we're going to build on that if it did work, and we'll do it again. And so I think philanthropy has an opportunity to pilot some of these wild and crazy ideas. And I could give you a few examples of those in our community. One of them is we are getting frontline team members into home ownership. One of the fastest ways to build wealth in this country is to own a home and pay it off. And we have people in our community, so relatively low cost of living in the middle of America. You know, our average home cost is between $150,000 and $160,000 in this community. You could build a new home here for probably $200,000 to $225,000. That's not out of reach for middle America. You know, so for the nurse who's married to the maintenance worker, they can do that. So they've got the work history, they've got the credit score, they've got the monthly payment. They just don't have the down. They don't have the down payment. And it's hard to come up with $25,000, $30,000. And you need even more than that if you want to avoid mortgage insurance. So a donor came forth to our medical foundation and said, here's $200,000. We want you to put 8 people into homes that are newly built homes. Here's $25,000 apiece for these 8. We encourage you to get the county involved, the city involved, and any other folks involved to make this work. So we've pulled together 15 or 20 leaders in our community that are putting up affordable homes. There are developers, there's bankers, there's other funders. The county has pitched in an additional $5,000 per new home. The city is pitching in an additional $5,000 per home per new home. And now all of a sudden we've got $35,000 in a down payment for what could be a $200,000, $225,000 home. You can get somebody into a good 3-bedroom, 2-bath home for that, and then they stay. And basically, it's a loan that's repayable by time of service. So here's $25,000, and it's automatically forgiven and taxed over 3 years. So it doesn't hit them on their taxes, especially hard any one year. And they can make that work over the 3 years. And after the 3 years, that's forgiven. and they are the proud owners of a home for the next 25 or 30 years. So that's one area where a philanthropist could say, yeah, we want to change. 55% of our homes are owned. 45% of the people in this community rent those homes. That percentage could change in a city of 50,000 like ours. Who wants to pilot that and show that it could work? Because the story of Hutchinson, Kansas is the story of middle America. If it can be done here, it could be done elsewhere. It could be done in North Dakota. It could be done in Oklahoma. It could be done in parts of the Southeast. We can do this and get people into home ownership where they otherwise could never afford it in some areas on the coast. Another example is with transportation. This month and this week, actually, we are surveying the bottom 20% of our wage earners in our health system, figuring out how they get to work. How far do they have to drive? Are they carpooling? Are they walking? What are they doing? Weather? We're asking them these questions, and we're taking that data in partnership with Dartmouth, and we're going to synthesize that data and use it to plan interventions around ensuring people can get to work. That may even include plug-in electric, like hybrid cars. We can charge them for free at work, where they can get there. So they go from unreliable transportation, which is a destabilizer in a family, to reliable transportation, where through these grants, through these philanthropic funds, the health system pays the lease, which helps build that housekeeper or laundry person's credit score so that they can eventually qualify to get into a home. We're helping them build that. That'd be another example of what we're doing. We, in January, we eliminated all out-of-pocket expenses with the exception of the emergency room. We eliminated out-of-pocket expenses for our health system employees who get their care in our hospital. That's not like there's no workaround there. There's no trick. We literally eliminated them. You can come in here and pick up your drugs and not take out your wallet other than your ID. You don't have to pay for drugs outside of your premium in your health plan, which comes, through payroll. You can come in here and get 9 months of prenatal care and a delivery, no out of pocket. An MRI, no out of pocket. A joint replacement, no out of pocket. As long as you get your care here, for the first time in history, housekeepers are able to afford the very care they're providing to other people. We're looking for resources, academic resources, particularly around tracking the outcomes associated with that. And now we need help building out an employee health plan that will mirror that kind of risk. Right now, we're building out that employee advisory council, figuring out now how do we incentivize good health, because we've gone at risk for these people's care. And utilization is way up. Now, what's happened is we went from 50% of our employees spend not even in our hospital and going to other hospitals. Now that's up to 75% over a matter of 6 months. But now that they're utilizing it, how do we ensure they don't need to use as much of it because we're getting ahead of it with disease? And that means we may be changing what we're offering in our food and nutrition services department, or we may be incentivizing exercise or looking at health education programs or additional smoking cessation strategies or addiction stuff or behavioral health. We may be looking at these things differently. Philanthropy coming in, helping us figure out how to have the healthiest workforce in the United States. We now need that because we've made healthcare available to all. So these are some of the examples that we can do. I don't know that that takes millions of dollars, but it takes the resources that will allow us to take risks when we have a 0.6 profit margin right now, less than 1%. We don't have the margin to make mistakes here or to take many risks, and we're taking them because they're necessary. Philanthropy can help us take some of those risks where we're not punished the same way if one doesn't work.
This season of this show, we're spending a lot of time talking about aging and elder care, and that's a theme that emerges especially in rural places as people are aging in place, leading to isolation and loneliness. I'd love to hear your thoughts about some of the programs as you center community, things that you're familiar with that are helping solve some of those issues. How are you really working with your older adults in your area?
So I remember when, it was 6-7 years ago, I was visiting with a medical student and a researcher at the University of Minnesota on what we were calling the 2030 problem. And 2030 is when the last of the baby boomers turn 65. And at that point, we will have completely overwhelmed both our hospital or healthcare systems and our skilled nursing facilities, because that generation of Americans is entering the final season of their life without enough money, without enough relationships, and without enough purpose to thrive. We don't know as a society what to do with the old and the lonely. We don't know what to do with them. And yet, the majority of the healthcare spend in an American's life is often in the last 6 months of their life. We don't know how to end well. And so I go back to some of the research with the blue zones that was done years ago. And it's since been purchased, I believe, by Adventist Health on the West Coast. But they studied the healthiest people in the world, where there are more centenarians than anywhere else in the world. And those people that make it to 100 finish with purpose. And of course, what they eat matters, their activity matters, but they're not people in CrossFit gyms. They're people that walk. They're people that are active. They're people that have relationships. They're people whose voice and perspectives are valued. They have purpose with kids, with grandkids, with their faith communities. And I think we have an opportunity here, and are doing some of that same thing. So one of the things that's very important to older adults here is the integration of physical and spiritual care. And so we have a chaplain here who launched a project called I Have Hope. It's a campaign across the organization. There's signage in every hospital room and in all the hallways that say, if you see someone wearing this sign, if you see somebody wearing, it's a puzzle piece, I could show it to you. If you see somebody wearing this sign, ask them about I Have Hope. And if it's a person who is seeking a hug, they'll find one. If it's a person that's seeking a conversation and human connection, because that's the source of hope for them, they'll find that. And if it's a person that is seeking prayer in Jesus' name, they'll find that too when they ask for it. And it may not always be the caregiver that they approach initially is the one that can meet that need, but we're sure that that person exists here and we can find it for them. And so I think meeting people where they were, we just recognized as a mission moment recently. There was the wife of a local minister who was hospitalized, and she was in the shower. And she asked about this I Have Hope piece. And she said, well, what would give me hope is to sing praise and worship music. And so this particular team member happened to share her faith and began singing with her in the shower as they were bathing her. And she said, of all the things that happened to her as she's getting up in years, of all the things that happened to her during her care delivery process, that meant more to her than anything. And it's important as we build something like that out that we're not exploiting anyone, or we're not violating the trust or sacred relationship between a care provider and a patient by forcing something on a patient, or a patient forcing something on a caregiver. But when both are invited and there's clarity around that, there's structure or boundaries around that, it can be amazing for our elder adults, and really all of our patients. But especially it means something to them, because sometimes what they're after is not another med. What they're after is somebody that will pray with them, or somebody that will listen to them or encourage them. And so I think it begins by asking our older patients, our older community members, what do you need? What's most important to you? And let's build systems around that, around what's most important to them.
Well, and I would assume oftentimes when folks are in the healthcare system, they're there as a patient. They might be one of their darkest times. They're there seeking that guidance. And I think what you shared of, it may not be the next medicine. It might not be the next script. It's going to be that moment of connection that's going to pull them through.
It is. And if they, for example, if their background is not Catholic or Protestant, but it's Muslim, or they don't have a faith background per se, but a different set of values, it's just about aligning them with somebody who can really connect with them at that level, and meet them where they are. It's really the reintroduction of kindness and empathy in healthcare.
I think it's really interesting that you are pulling together community leaders as well, and seeing yourself and the hospital system as a leader in that space, whether you're working with your superintendent or your city council or your county commission. How are you working within community to ensure that those same set of values are being driven out beyond the walls of the system?
Well, we were handed one great example and opportunity about a year ago when a local philanthropist stepped forward and said to me, I want you to meet the CEO of the YMCA of Greater Wichita. He wants to put a new $30 million YMCA in your community, and he wants to put it on land that you own as a hospital system. So we sat down, and there was a very overt initial ask, like, hey, we're here to put a Y on this land. And we had 30 acres, and we could have given him the back 10 acres of that 30 acres, which would not have been as desirable, or we could have given him the front 10 acres that was at one of the busiest intersections in the city. And we quickly decided we're going to give them the 10 most valuable acres, which would have been where we would have placed a new healthcare delivery system in the years to come. We gave it to them, believing that that is the front door to healthcare delivery moving forward. And they agreed then to build a childcare center and run a childcare center for our employees in exchange for, but we put up the building, but they run the childcare center. And so we have an international space museum here called the Cosmosphere. It's a sister to the Smithsonian Museum in DC. And the Apollo 13's capsule is here, and some of the Apollo 11 first lunar landing gear is here. And so it's a space town, right? It's part of our identity. And so we've partnered with the Cosmosphere to design and build that childcare center in partnership with our certified community behavioral health center, so that there will be 3 separately run systems within that building. One is a learn and play center for kids with special needs who have exited traditional childcare. Then there's a traditional childcare space, which will care for up to 100 kids, run by the YMCA. And then there's this Cosmosphere for our youngest tourists from 0 to 5. And so it's this space museum for infants to toddlers. And so both of the Learn and Play Center and the Child Care Center can take field trips on a regular basis into this space center, but it's available to anyone across the country to bring their young kids there. And we're fundraising for that right now. But because we're doing it together, it's a far more compelling project for a philanthropist to get involved in, because we're introducing STEM education to kids starting at birth. It exists. I don't know anywhere else where that exists. And here we are in the middle of America figuring that out. So it's not a huge project. It's $8 million or so to put this thing up. But all those organizations have agreed to work together. The city is working with us and are paying for the majority of a stoplight, because it's going to change traffic so much in that region, the area. The city sees the value. We're partnering with a little bit. The hospital and the YMCA are putting in a little on the stoplight, but for the most part, the city's going to do their part, take care of it. But there's really been nobody as far as putting up the Y and putting up this subsequent childcare center. It's called Cosmo Kids. There's no one that's saying, oh, but don't do that. And it's, there's no tribalism in it. There's nothing like that. It's just, how can we make this work? This is going to lift the self-esteem of the whole city. If we do this together, let's do it. And if we can do this, we can do other things. So I think we just look for the wins. I don't think we have to start with the hardest thing, Aaron. You start with the easy stuff and work toward the harder stuff. We're almost culpable. We're responsible if we did not respond making this work. When the Dillon family that founded Dillon's Grocery Stores comes and asks us to do this, and we look at this and we say no because we want to hang on to that land for our own potential future use, we're culpable for that. I mean, this is the whole community is excited about this, right? So we just step into the easy spaces first and just look to get to yes. And then we can work toward harder things later. And you start with the willing, people who are willing to collaborate, and then let them convince the unwilling. Often we want to go to the hardest thing to make the biggest difference, but the reason why it's the hardest is because there are people in the way that are unwilling, and there's barriers in the way that just you have to work through. So you just build momentum by starting with easier wins, and that it didn't get any easier than the YMCA saying, "Can we have this land that you own?" Yes, you can have the land, and can you watch our kids for us? Because there's no stronger brand in the state for childcare than the YMCA of Greater Wichita.
Yeah, and having a seat at the table, right? There's another colleague of mine that says, "Look for the coalition of the willing," because that's how action happens.
I'm taking that. I'm going to reuse it. The coalition of the willing.
Yes.
It isn't always the mayor. Maybe it is the mayor, but it doesn't have to be the mayor or the superintendent of schools or the health system president. Sometimes it's the connected teacher. It's the gas station attendant who knows everyone, who has favor with many. And if you can get them on board, if they are driving the change, it'll go.
Yeah. And it's knowing who those people are, but that requires being in that place and listening and not going in and saying, I have this great idea. We need a childcare center. How am I going to implement the childcare center? It's how are we collectively going to make something really incredible happen?
That's right. Interestingly, we tried that as a health system 3 or 4 years ago. We tried to put up our own childcare center, run it, administer it, and we're going to build a state. And reality is, we don't do that well in a health. We don't know what we're doing with that, but we know people who are good at that, who do that well, and it's about partnering with them and asking them, how do we set this up, right? How do we do it right? And they know. And when we're willing to work together, people are willing to support it.
I think it's great. I'd like to pivot a little bit and talk about preventative healthcare and how hospitals can play a role in keeping people out of the hospital. I know that's a real pivotal point for the work that you're doing. How do we get ahead of some of these chronic health issues that, especially that we're seeing, that might be slightly different in rural or remote places?
So there's a couple different ways we can go. Something that's unique about our system that I would encourage elsewhere is that we oversee or have enveloped as part of our health system, it's an affiliate of our health system, a certified community behavioral health center, the CCBHC, which is a new federal designation, newer anyway, and it gets more than adequate or at least adequate funding to serve people suffering with mental illness or substance use disorder. But when you look at the statistics, that may be most of us. Anxiety, depression, or we know somebody. 80-90% of us in Kansas I just looked at a survey recently of eligible voters. 80 or 90% either are struggling with mental illness or substance use disorder, or know somebody immediately in our circle that is. And so that's so many of us. And so they are funded to address the vital conditions, as the Ripple Foundation would call them, the vital conditions of the population we serve, or the social determinants of health would be a broader way of saying it. But to address the things that lead to the things that lead to people being in our emergency department. And so we have an opportunity to integrate those behavioral health services and substance use disorder services into our emergency department so that there's a very quick handoff and we don't come back. Or getting ahead of them before they even end up in our ED, but by addressing them with transitional housing, reintegration after incarceration, food support, educational support, family therapy support, crisis intervention services. All of those things can happen before we end up in an emergency department. We can go to those resources, and we have it. It's an organization called Horizons Mental Health Center. We're very proud of it in our health system, and they've been really a fast growing organization as well, as they've really reached out to connect with and serve those preventive needs within our community. And the reality is, we don't care what part of our system or what resource within our community is handling that, just so long as someone is. Right now, we had some significant funding cut around Meals on Wheels, so we're concerned with that right now because that can send somebody into serious sickness, right? And so we've got a hungry elder population here in the middle of an agricultural community in the middle of America. We're 100 miles from the geographic middle of the United States, and we have hungry seniors in our community. And so right now we're grappling with that. Is it the Salvation Army? Is it micro food banks or mini food banks? Or is it the school system that has a food program? Is it the YMCA that also deals a little bit with that? Is it our health system and Horizons Mental Health Center? How do we collaborate around that to ensure that the calories get into the right places so that people's bellies are full, right? How do we do it? And so we're addressing those things, I think, together. But what I've done in the past, and I'm new enough here, we haven't done this here, but in my past posts, is we got people together once a year and we asked them, what kind of shape are our kids in? And we put up a pyramid. If you can picture just a triangular pyramid, and at the top of the pyramid, we got the schools together in one corner of the room, the law enforcement together in one corner of the room, faith community in one corner of the room, and the health system, healthcare folks in one corner of the room. And we had them fill out the top of the pyramid, the outcomes that mattered most to the people they served, which in education would be graduation rates or academic attainment or whatever. In law enforcement, obviously, incarceration rates or lack thereof would be an outcome they care about. And for us, it might be diabetes, or it might be mental illness, or it might be whatever those health outcomes that matter most to us. We put them at the top, and in the middle of the pyramid, we would line up what are the decisions that individuals make that lead to those health outcomes, indicating an individual responsibility. So I show up to class, I don't. I act out in school, I don't. Right? I come prepared, I don't. In the decisions that people make to end up encountering law enforcement in a negative way, right? What are those decisions they make? And then in healthcare, am I taking my meds? Am I eating a Snickers? Right? Like what am I doing that's determining that? But on the bottom rung of that pyramid, we would fill in each of our respective disciplines the factors that lead to the decisions that lead to health outcomes. That we call the root causes or the human condition. And interestingly, at the end of the exercise, when we lined them up, all the pyramids next to each other, all four, the bottom row is almost always the same, with very little variation. Came down to poverty, housing, food, lack of access to food, gaps in access to healthcare. It came down to the human condition. So we would all agree, all right, we're going to put our disposable or our extra, our other duties as assigned, are going to go into one thing, and that thing is, right, we chose. And in the last year I was in Lake, Kansas, it was food. We were going to solve childhood hunger over the summer. And so we organized all of our resources around No Hungry Kid in the summer of that year. And we were able to really make a difference in that and develop some sustainable models around continuing that. And I think it's important that we get together and we think, well, first of all, how are our kids doing? Do their teeth hurt? Are they hungry? Are they cold in the wintertime? What do they need? And we ask those questions and answer them. Then we can develop strategies around that.
It's so interesting. We started as an arts and cultural funder here at Roundhouse, and we funded primarily arts organizations in our smaller community for the first few years of the lifespan of this organization. But after the third year, our founder said, it's really hard to be creative when your teeth hurt or you don't have access to clean water or healthy food. So it's just the parallels that I hear. It's the same no matter where you live, no matter what you're doing. Yep. It's those root causes. And how do we come together to say, we have to do a Band-Aid on a head wound first. We got to make sure that we get the kids fed over the summer.
Yep.
But then what? Then how do we do that collectively?
You pull together the coalition of the willing, right? Yeah. It's so ironic. I'm leaving here in 3 hours and I'm going to go speak at the Salvation Army's annual dinner. You familiar with the Salvation Army?
I am. Yeah.
And so one of their, I don't know, mission quotes, or one of the most compelling quotes or guidelines they use is from their founder, General William Booth, who was famous for saying, after 60 years of doing this exact kind of work, he gave this speech at the end of 60 years and just 2 or 3 years before he passed away. And he said, while women weep as they do now, I'll fight. While children go hungry as they do now, I'll fight. While men go to prison in and out, as they do now, I'll fight. While there is a poor lost girl upon the streets, while there remains one dark soul without the light of God, I'll fight. I'll fight to the very end. And I think we have to agree on a common purpose, whatever that purpose is. We have to agree on a common purpose that says, that ain't right, because it's not. We're going to fix it together. We might have different motivations or values or reasons for why we join this fight. That's okay. We're the United States of America. We all have different reasons for why we jump in. But can we agree no more children that are hungry? No more unnecessary incarcerations, right? No more kids on the streets. Like, we can agree on those things. And so we're going to fight for it together.
I love that. And it reminds me of the conversation you and I were in for the Kansas Rural Health Summit, because I think that truly is how you embody who you are as a leader as well. I think that same day of that event, you were hosting a dinner for your whole staff at your house.
Multicultural potluck?
Yes.
Yeah, we do one of those every 6 months where my wife told me I overdid it. It was 120 people there. She said, where are you going to put all these people? I said, well, right next to each other. That wasn't an adequate answer for her. So we moved it to the zoo after that. Like, literally, there's a big community room at the zoo or the nature center or wherever, because 120 people is too much for our house. But we did. We had people from 30 countries brought dishes into our front room. And I just fell in love with the idea of I watched a Mennonite farmer who brought blackberry pie and homemade ice cream. I actually think it was his wife that brought it, but they brought it together. And sitting down with a Pakistani neurocritical care physician specialist who had just moved here a few years ago to finalize his training and moved out to Hutchinson, and sitting there watching them for an hour get to know each other and ask questions of each other. They couldn't have been from more different backgrounds. Yeah, one's Christian, one's Muslim, one's from the East, one's from the West. And they'd never eaten each other's food, but they were doing it that night. And it was interesting that the ones that taught them how to do it were their 2-year-old boys, because they hadn't been taught to fear. And so they knew just what to do. There were toys in the middle of the floor and they could play. And since they were playing, well, I might as well sit down and get to know this guy. And that's how it started. And that's how it can start. And I think that's the United States of America that we dream of. And we have to, our own words, our own creed is staring us down. And I think we can get there.
Well, and rural places are that microcosm. I think sometimes rural gets a bad rap of being monolithic and being only one certain way. But the reality is it's a melting pot, just like the rest of the states.
It is. And solutions that come out of here can work elsewhere. We can try crazy cool things here because our autonomy is our superpower. We don't have to go to some big city corporate headquarters or way out of our area to ask permission to do something. If we can convince 12 board members it's a good idea in our health system, show them how it sustains, we can do it. And we can try things here. We can make mistakes and learn from them. And we have an obligation to do that insofar as it benefits our community.
I love that. And I love that you're learning not only from the successes, but from the mistakes. We call that paying tuition in our office.
I love it. I'm taking that one too.
There you go.
Coalition of the Willing, and we call it paying tuition.
Paying tuition. That's right. Because that's how we learn. And you have to screw stuff up to figure it out. Right. And we just ask for grace through those messes because we're learning.
That's the message to philanthropy. Back to this rural philanthropy discussion is early on when I accepted grants and we failed, I felt a sense of shame. Like they entrusted us with these dollars in a place where dollars are so scarce and it didn't work. Like I almost struggled facing off with the funder when I had to go back and say it failed, it didn't work. And the ones that were so effective are the ones that say, no, you learned something. You learned something from it. Let's not miss the lesson. And it wasn't a loss. It was a gain because you learned something. Let's keep going. Let's do another one. And that was just a real breakthrough for us when we realized it's actually the reason they're funding it is because we don't have the margin to fail where they do. Mm-hmm. And obviously they want it to be as good a chance to succeed as possible. But I think philanthropy offers the opportunity to try edgy, innovative stuff that we wouldn't otherwise be able to do. And just gives us the freedom to do our best at it and learn from it. But if we fail, it's not the end of the world.
I want to touch a little bit on stuff that's happening at the federal level and how that's impacting rural healthcare. There was recently a bill passed that might impact how healthcare is done across the board. How are you seeing that step into your space? I know that there's concerns about losing Medicaid funding. I know that you're already facing budget cuts. How does this play out for your system, the communities you serve?
This comes to us as we have just begun to recover from COVID-19. So we did not weather COVID well. Our health system lost 10%, had an EBITDA margin of negative 10%, fiscal year 23, 2 years ago. Fiscal year 24, we cut that in half to 5% or a $10 million loss, but we're eating through our cash reserves very quickly. And now at this point, we are looking at, we just finished this fiscal year. If everything hangs in place, just barely, like a $500,000 profit on a $199 million budget. 0.6%, I think is what it ends up being, 0.6% profit margin or an EBITDA margin. And then this comes. And then this big, beautiful bill is passed and there's sweeping Medicaid cuts. And what they do is they put in this $50 billion rural transformation bill in there to try to to get it through politically, essentially, which is a small fraction of what they're cutting out of the Medicaid system. But it's an effort to try to put that back into rural. But already, just a few days ago, there's a Modern Healthcare article that came out around how rural hospitals are choosing our urban hospitals are choosing to designate themselves as rural hospitals in some loophole within the law so they can pull down those $50 billion. So not even all the $50 billion end up in rural hospitals as it was defined or intended. And so we are having to constantly reinvent ourselves if we want to be able to continue to sustain our mission, which we do. So right now we've frozen wage increases. We are freezing capital projects right now that we need. We're delaying maintenance. We're deferring maintenance on our equipment, which puts us at risk in the future because we don't know. We don't ever want to have to do, a mass layoff or hurt the organization or its people in that way. So we're being conservative about it right now, but we're just in a holding pattern, waiting to see what happens. And it adds stress to the system for sure.
Well, and adds stress to your team, I would imagine, yourself included in that, which is a strain on the system as a whole. If people don't know what their next step is going to be, they don't know if their position's going to be safe,
Yep.
They don't know what tomorrow holds.
Yep, that's right. And what it does is that type of trauma or stress is the enemy of innovation, because we can't think further than next week or next pay period if we're stressed about that stuff.
Yeah.
We need to be doing this thinking 3 to 5 years out, because that's how long it takes to start moving the needle with population health.
Yeah. And I don't know what the solution is or if there's a solution. I think just talking about it in a way that helps people understand that while 50 billion seems like a lot if you're playing Monopoly or even in your own bank account, right? That feels like a lot. But divided amongst all 50 states, and that I don't even think that that's divided equitably amongst all 50 states. I think there's some allocated in another way from that 50 billion.
Mm-hmm.
And like you said, there's urban hospitals designating themselves as rural. There's confusion about what the administrative rules look like, if they're even complete. And then there's a real tight timeline on those dollars as well. I think it's the end of 2025 calendar year. And I know enough to get myself into trouble. So here I am chatting about something I don't know a lot about. But it does feel like it's a strain on the system. And regardless of what your role is within the system, even as a community member or a partner, you don't know what to do next.
Well, and that's where philanthropy comes in. It is a crucial part of our strategy moving forward. We have a relatively small medical foundation here who has an endowment from years ago, 30 or 40 years ago, that sits in there, and that's what we're using to fund some of this housing work, and we're relocating several dozen physicians here over a 5-year period, relocating them to our county, and there's with some support from the foundation for housing bonuses and things like that. But we have to really double down and lean into that foundation and call on philanthropists to say, we're not going to be able to replace our equipment like we would have otherwise been. We need your help. We're not going to be able to build out a premier maternal health program here to take best possible care of our moms in the region with the reimbursement as it is, and with Medicaid being cut, with over 50% of babies being born on Medicaid. We need your help. So we need your help to replace equipment. We need your help to fund new innovations. We need your help to help fund research here to help us improve this. We need your help. And so there is an opportunity for philanthropy to step into those gaps right now, and we need it more than ever.
Yeah. Thank you for taking a chance and jumping back on with me to tell this story. So moved and motivated by the work that you're doing. Your name comes up frequently when we talk about rural access to healthcare in the work that we do, of like, who you should talk to, who's doing it really great. And it's you.
That's humbling. I appreciate you sharing that. And we're all in this together for sure. So let's do stay in touch. I just want to thank you for giving rural people a voice. What you're doing is handing microphones to people whose microphones have been non-existent or their volumes turned down. They haven't had much of a voice. And you created a podcast around ensuring that rural American people are heard. You're giving them a platform to do it. And so that's not small work. It's very important work. And it's immeasurable, the outcome of it. So I just want to thank you for that. There are people that won't ever know to thank you for this, but their lives are being impacted because these people are getting a voice and they're getting the resources they need.
That's very kind. Thank you. Rural is in my heart, and it's important. And I didn't realize how much until I stepped into this space about 5 years ago and went, wait a minute, what do you mean nobody else is thinking about these communities, or not enough people are? So,
what are we doing here? Right?
That's right.
Yeah.
There's times in your life when you run into people in the most unusual places and they leave an impact on your life and the way that you see the world and how you look at partnerships or your work. Benjamin Anderson is one of those people. We met randomly at this event put together by a gentleman named Wyatt in Kansas, and it was such a gift to be able to hear him speak and to be on the panel with him during that and during that event and hear how he thinks about healthcare as part of the community. It's such an innovative way, recognizing when to step forward and when to step back. And I think that's such a valuable lesson for philanthropy. When do we push and when do we step back and let the community members on the ground lead? And sometimes it's not the traditional folks that we think it's going to be. We didn't realize, or in Benjamin's case, he didn't realize that the healthcare system was going to be an integral partner in this childcare work. And what a benefit for that community. So thinking creatively and thinking outside the box, allowing ideas and opportunities to flow is the way that this work really is magic. And we're so lucky to be a part of it. Thank you so much for listening. You can find show notes, transcripts, links to Benjamin's work and that of Hutchinson Regional Medical Center on our website, fundingrural.com. Thank you again for tuning in. We'll catch you next time.